Our last presentation of this session before the break is going to be by Dr. Brian DeRubertis. Dr. DeRubertis is Associate Professor of Vascular Surgery in our division, and he will present endovascular repair of juxta and suprarenal aneurysms. Brian?
Thank you, Dr. Quinones, for the introduction. It's a pleasure to have the opportunity to present today. As mentioned, I'm going to be discussing endovascular repair of abdominal aortic aneurysms, specifically juxtarenal and suprarenal aneurysms. These are my disclosures relevant to this presentation. I'm a proctor for the Geffen device and review films for them as well. So as by way of introduction, obviously abdominal aortic aneurysms are something that we deal with quite a bit as vascular surgeons. The incidence of aneurysms in the abdominal aorta is roughly 21 per 100,000 person years. Of these, the vast majority are infrarenal in nature, or specifically abdominal in nature rather than thoracic. About 20% of aortic aneurysms are in the thoracic aorta. About 80% are in the abdominal aorta, and most of these, as I mentioned, are infrarenal in nature, with only about 5% being suprarenal or juxtarenal in nature. For infrarenal aneurysms, we have some fairly good tools to treat these, and I think there's been really a lot of progress in the last 2 decades on treating infrarenal abdominal aortic aneurysms with an endovascular approach. In patients like this that have a nice infrarenal neck, meaning 1 to 2 centimeters of non-diseased, non-angulated aorta below the renal arteries, aneurysms that are really confined to the infrarenal aorta itself or the aortic bifurcation, who have nice, appropriate common iliac seal zones. So basically, what this means is that you can introduce an endovascular prosthesis through the femoral arteries, bring it up to the infrarenal aorta, and basically deploy this graft with expectation of getting good wall apposition at the seal zones, both proximally, just below the renal arteries, and then distally in the iliac arteries. So patients with this type of anatomy can have an endovascular repair, often fully percutaneous these days, in operative times of an hour or less, provided it's this straightforward. And these days, with the current technology we have, you can expect that these patients with good anatomy will be able to undergo these procedures with mortality rates less than or around 1%, excellent long-term patency of the graft limbs and the graft itself, with excellent long-term aneurysm exclusion. Now, the problem is that many of the patients that we see, certainly the ones that we often get at UCLA here, are not these sort of chip shot cases with nice landing zones for our endografts. And we have a lot more patients with this type of anatomy, either no infrarenal neck or very short infrarenal necks, or patients with excessive angulation of their infrarenal neck. So the question is, what happens when we apply these infrarenal grafts to these type of patients? And as you might expect, the outcomes are not quite as good as patients that have a very straightforward anatomy. In this study published in 2011 in Circulation, the authors used an imaging database, the M2S database, to look at aneurysm sac expansion over time following endovascular aneurysm repair. They looked at over 10,000 patients and found that the 5-year post-EVAR sac enlargement rate was around 41%. So, if you think about this, that means 41% of these patients who we thought we fixed aneurysms on still had their aneurysms grow at 5 years. Also of note, and probably most important in this study, is that 58% of the patients that they evaluated in this database had aneurysm anatomy or aortic anatomy that was beyond the IFU or instructions for use for the devices. So, what that means is when you start pushing the limit of what these devices are designed to do, your outcomes suffer in the meantime, or as a result of that. And so one of the things that they noted was that non-adherence to the IFU resulted in increased likelihood of early and late sac expansion over time. So one of the areas that we sort of pushed the envelope the most in terms of the IFU or the instructions for use for the devices is at the infrarenal neck. So we've tried to get away with using short necks, 1 centimeter or less in some cases, with these infrarenal devices to try to get a seal. And that's because of the increased morbidity that comes with doing open juxtarenal or suprarenal aneurysm repairs compared to infrarenal repairs. Just as a way of definition, so the first thing I want to point out is infrarenal aneurysms are basically defined as limited to the infrarenal aorta with an appropriate clamp zone or SO zone below the renal arteries. A juxtarenal aneurysm is generally defined as an aneurysm that does not involve the renal arteries, but because of the proximity to the renal arteries, you'd require a suprarenal clamp to sew on the anastomosis, the proximal anastomosis, compared to a suprarenal aneurysm in which the aneurysm extends to the renal arteries and involves either one or both of the renal arteries. The reason why this distinction is important, as I mentioned already, is that infrarenal aneurysms, these can be repaired at most centers with the expectation of low morbidity and low complication rates with an infrarenal clamp, and we also have appropriate devices to treat these endovascularly. On the other hand, juxtarenal or suprarenal aneurysms require a clamp above the renals. This obviously obligates the patient to some renal ischemia time. Often the aorta between the renals and the SMA is diseased as well, so sometimes we're actually doing supraceliac clamps for these patients with an open fashion. And the complexity of these procedures is obviously hard as well. Obviously, there are times where you have to reimplant renals or do a visceral and renal patch to achieve the aneurysm repair. And finally, there's been no available endografts for these type of aneurysms until a couple years ago. And this is where we really want to see some progress, obviously, because these more challenging aneurysms to treat operatively have higher degrees of complications associated with them, both from the cardiac and pulmonary standpoint, because of the more proximal clamp zones, as well as renal dysfunction. These patients, certainly with juxtarenal aneurysms, have a higher rate of renal dysfunction after open repair compared to those undergoing infrarenal repair, and that risk of renal dysfunction increases as our clamp time increases as well. So these are all the reasons we want an endovascular strategy for these patients, but until a few years ago, there really wasn't a good option. At that time, many of us started using such techniques as either physician-modified grafts or parallel graft techniques where there's a side branch basically going alongside a standard aortic endograft to try to achieve flow into the kidney arteries or the visceral arteries while still fixing the aneurysm with basically a tube graft placed endovascularly. A couple years ago, the Geffen device became available, and that's been really the mainstay of treatment now for these juxtarenal or suprarenal aneurysms, or sort of simple suprarenal aneurysms. And then I'll briefly touch on some novel investigational devices. But the bottom line with all of these devices and techniques, they're meant to basically raise the seal zone from that diseased infrarenal neck to an area just above or at the renal arteries where you have a healthier seal zone, while still maintaining flow through the target branches that come off of those areas. The first sort of approach to this for our center had been the use of physician-modified endografts, and these are grafts that are basically designed for the thoracic aorta, in which we place holes or burn holes or fenestrations in the graft to allow perfusion to those branch vessels. These are done first by a meticulous amount of preoperative planning, in which we use 3D rotational reconstructions, as well as what we call best fit or manual centerline adjustments, to try to predict exactly where the SMA or the renal arteries will come off on the endograft. And that information is basically then used to design our endograft or place our fenestrations or our scallops in this case at appropriate spaces. So this just shows the fenestrations for the SMA and the two renal arteries and a scallop for the SMA. We sew on radiopaque marker bands that are visible here once the device is reconstrained within the delivery catheter and evaluated under fluoroscopy. The general, this is the first patient we treated with this approach, and you can see he has a fairly angulated neck, an aneurysm or diseased aorta that goes right up to the renal arteries. His sort of appropriate best seal zone was basically around the celiac artery or between begin about halfway between the SMA and the celiac artery. You can see that here. This is all diseased aorta up to about this spot over here, with the aneurysm extending right up to the renal arteries there. This is our general technique for these procedures, bilateral percutaneous femoral access. We come from the arm or the axillary artery to deliver some of these covered stent grafts into the target branch vessels. This is our general approach of sewing on an axillary conduit, a Dacron graft sewn to the axillary artery, through which we place a number of sheaths that we then direct into the visceral or renal branches. This angiogram shows the aorta here with the aneurysmal aorta down here. These are the renal arteries there and over there. And what we see here is our sheaths and our wires and diagnostic catheters up from this approach, from a femoral approach into this renal artery, and then several of these sheaths coming from the axillary conduit down into the SMA and the other renal artery. Then we start deploying our endograft here, and as we deploy it, the top of this endograft opens up. We then expose these fenestrations or scallops, and then once the graft is open and these are exposed, we then pull our sheaths back up, go through the top of the graft, through the fenestration, and then into the target arteries. Once we have our sheaths through the fenestrations and into each of the target arteries, we can bring covered stents through these sheaths and position them there as we finish deploying the endograft. This just shows the deployed endograft. Then we are ballooning this to sort of mold this graft against the aortic wall and get this graft to oppose the aortic wall and seal over there, so basically preventing more blood from getting around it into the aneurysm. Once this is done, we then deploy these balloon expandable covered stents to bridge the gap between the fenestrations here and the target vessel distally. And then we see the completion angiogram with flow through the aorta, absence of any flow into the aneurysm here, and preserved renal and visceral branches. This is what the patients sometimes look like when these patients go well. This is a patient on post-op day number 1. He had fully percutaneous access, a 4-hour procedure time, extubated in the cath lab, and discharged literally 3 hours after this picture was taken at 6 a.m. And generally when these go well, the patients look better than the surgeon does in the following day. So the other technique that many have used are parallel graft or chimney approach. And this basically, the technique here essentially involves using a non-fenestrated or non-scalloped endograft, so a tube graft placed within the aorta, while you bring catheters from the arm or axillary access into the renal arteries to deploy a covered stent alongside this tube graft. So you see the configuration here with the tube graft here in the infrarenal aorta, and then these chimneys or parallel grafts alongside of it. The overlap zone here is designed to be fairly long to minimize the chance of a gutter leak of blood getting basically between those graft components. This shows the technique. This is some images from our friend Jason Lee up in Stanford. This shows the thoracic endograft, the infrarenal endograft deployed up to a level above the renal arteries, but he has sheaths in each of the renal arteries through which are delivered the covered stents. And you see here simultaneous ballooning of the infrarenal aorta and the covered stents into the renal arteries. This balloon is deflated first to prevent crushing of these grafts. A lot of the work, as I mentioned, on Juxta renal or sort of more simple suprarenal aneurysms has been sort of shifted over toward commercially available grafts, specifically the Geffen device. So this device has been available for just over 2.5 years, I believe. It's based on the Cook Zenith platform. It's a modular platform in which you have a fenestrated proximal cuff here, through which you can design up to 3 large fenestrations or 2 fenestrations and a scallop. And again, the position of these fenestrations and scallops are based on meticulous preoperative planning from the CT scan and the various reconstructions we do from that. After achieving these measurements and designing the graft, you then order the graft from Cook. It takes about 4 to 6 weeks to have this custom made. So each device is made specifically for a particular patient. And then the distal end of this is a bifurcated component to complete the repair. This just shows some close-up pictures of this. Again, the scallop for the SMA in this case, and these are the fenestrations that have marker bands that can be seen under fluoroscopy, as well as reinforcement of the fenestration itself. There's obviously a number of instructions for use for this as well. There's certain anatomy that this is more appropriate for and less appropriate for, and so again, adhering to the IFU of this device is probably important in terms of late-term outcomes as well. But again, even with the other devices, we do tend to push the envelope with this device at times as well. This just shows a general deployment. Typically, with a Geffen device, you're usually having a scallop for the SMA and 2 fenestrations for the renal arteries, although again, this can be configured in a number of different ways. But by and large, we always approach these coming from below. So the main fenestrated cuff is deployed all the way down. It's open at the bottom. We then come up from the bottom through the contralateral femoral artery to get into the graft, cannulate the fenestrations, and then get into the branch vessels. Once the sheaths are through the fenestrations into the branch vessels, the renal arteries, we then complete the deployment of the graft, balloon the graft to get a seal up here, and then we deploy our covered stents into the renal arteries. This is a typical patient that we treated here with a Geffen device, and you can see there's no flow into the graft, and there's good flow into the renal arteries. Here's SMA. Let's see. Yeah, SMA, one renal there, and another renal there. So one of the newer technologies that is not yet FDA approved, but it's interesting and currently under investigation is the Nelix device. And this is basically a device that is comprised of a couple of covered stents, balloon expandable covered stents that go from the iliac arteries all the way up to the renal arteries. And then there's an endo bag, or a polymer-filled bag that you fill after deployment of the covered stents. And the purpose of this bag is basically to fill the aneurysm sac and basically obliterate that aneurysm space, or that sac space. So this just shows the two balloon expandable covered stents. They're deployed, and then the endo bag is filled, basically obliterating the aneurysm space here. The advantage of this device, I think, is that it really doesn't require a lot of proximal fixation for your endograft. So potentially this could be employed for very short-necked aneurysms, in part because of the fact that this polymer bag fills this aneurysm sac itself. One of the big potential advantages of this device, because of the fact that this bag is filling the sac, is that it can obliterate some of the type 2 endoleaks that ultimately become problems for us after standard aneurysm repair, either through the IMA or lumbar vessels. Whether this will ultimately be a truly effective device for short necks or suprarenal or juxtarenal aneurysms is yet to be seen. Just real quickly to review some of the literature on these different devices. First thing I want to point out is when you look at patients treated with fenestrated endografts or those treated with a chimney approach or the parallel limb approach, the main thing to note here is that target vessel patency is really quite good. 98, 96% primary patency in these, across the board in some of these bigger series. So the technical success rate with the operation is quite good, and the patency rate of these fenestrations or parallel limbs is quite good. Now, of note, several studies have shown that as you increase the number of chimneys or parallel limbs for the chimney approach, your patency rates does seem to suffer. So I think up to 1 or 2 chimneys or parallel limbs is pretty effective in terms of high degree of primary patency of those limbs. As we get to doing 4 chimneys or 3 chimneys, it's probably a little less effective. In looking at one of the more contemporary series published in JVS in 2015, specifically about fenestrated endografting, some of the things to note are the relatively low perioperative mortality. So these are patients with obviously the whole host of vascular diseases and associated comorbidities who have complicated aneurysms, either juxtarenal or suprarenal aneurysms, with a mortality rate following fenestrated repair of 1.7% in a fairly large contemporary series. So it just basically shows that these patients do fairly well when treated with an endovascular standpoint in terms of their perioperative mortality. And looking at some of the series, both single center series as well as some meta-analyses on this topic, we find some pretty consistent trends across the board when comparing open surgical repair with one of these percutaneous or endovascular strategies. We tend to see lower rates of perioperative mortality, lower rates of renal dysfunction, as well as lower rates of postoperative complications. In this particular study, that's true for both mortality and perioperative complications that were reduced in the fenestrated endograft group relative to the open group. This study, which was a large meta-analysis published in 2013, looking at patients undergoing almost 2,000 patients undergoing open surgery compared to almost 1,000 undergoing fenestrated endografting, to about 100 undergoing the chimney approach or parallel limb approach, found similar patterns. Essentially, the first thing to note is relatively low mortality across the board, but certainly lower rates of renal dysfunction in those patients undergoing a fenestrated or chimney approach relative to the open approach. The same is true in terms of the trend toward decreased complication rates in those undergoing fenestrated or chimney approach. One of the things to point out in this study is that the fact that the number of patients undergoing the chimney procedures is relatively low compared to our experience with both open surgery and fenestrated grafts. And I already mentioned that as you increase the number of chimneys, these parallel limbs tend to start suffering in terms of their patency. And finally, in this study, they actually showed a significantly increased risk of stroke in those patients undergoing a chimney approach because of the obligatory arm access that's required with these procedures. So a rate of 3.2% stroke rate in the chimney group compared to basically 0.3 and 0.1 in the other 2 groups. The other thing to note in this study is that they had a higher an increased risk of type 1 endoleak, which is certainly a problematic type of endoleak in those patients undergoing chimney approach. So the chimney versus fenestrated endograft discussion is probably not yet closed, and the final answer is not yet out. But there's certainly been a movement toward a fenestrated approach for these juxtarenal and suprarenal aneurysms as these devices have become available and more widespread. Finally, in this study, specifically looking at FEVAR and chimney, again, same sort of trends, low overall mortality rates, possibly a lower rate of renal dysfunction in this study with the fenestrated approach compared to the chimneys. So in conclusion, I'd say that open surgical repair of juxtarenal and suprarenal aortic aneurysms carries increased risk of complications compared to standard infrarenal repair, and thus endovascular strategies or solutions for these aneurysms are really ideal in many ways. Physician-modified endografts and these parallel limb technologies or techniques are useful because they can be individualized to the specific patient. They can be done with off-the-shelf devices without having to wait for a custom device, and they were our mainstay of treatment before having access to Geffen. Now with the fenestrated technology with custom-designed endografts that are commercially available, we've seen, again, a trend toward reduced mortality, perioperative mortality compared to open surgery, and reduced rates of renal failure and other complications. And I think this is probably going to be an important area going forward in the future. Thank you.